Hi everyone. So I was here last week, so some of you may recognise me. My name's Nosheen and I'm one of the diabetes and endocrine regs at the Northern. So I'm just going to share my screen, so just bear with me a second. Okay, can everyone see that? Yep, great.
Yeah.
So I'm just going to get it up on my phone as well so I can be one step ahead. So there's a few bits. It is going to be quite interactive, a bit more so than last week, really. There might be a few bits that it might be handy to have a pen and paper just to make notes, because I've got quite a few case studies and there's a bit of flipping sort of back and forth between slides, you know, describing the case and then asking the questions. So it might just be handy to have a pen and paper. You happy for me to just crack on? Yeah. Okay, so we've got three parts of the presentation. The first part is about hyponatremia. Second part is about adrenal insufficiency, and then we've got about, I think, 6, maybe less, cases at the end that we'll go through. So we'll start with hyponatremia. As you all know, it's something that we see every single day. I think probably I get at least one referral every day, sometimes 3, 4, 5 referrals as an endocrine reg, and I also see them quite commonly out of hours as a medical reg. So we're going to go through first how we classify hyponatremia, the symptoms of hyponatremia, the causes, investigations, and treatment, because we don't know what treatment to give a patient for hyponatremia unless we know what the cause is. And then I'm going to go through a few pitfalls. There's a quick slide on my references, and then we'll move on to adrenal insufficiency or adrenal crisis, and then we'll go through the cases at the end. So first bit of the interactive session. Can anyone pop the hand up or just, you know, put the microphone on and tell me, there are multiple different ways of classifying hyponatremia. Can anyone tell me one or more of them?
I know it's broken down to mild, moderate, and severe.
Yep, that's correct. And do you know what is mild, what is moderate, and what is severe?
I think severe is less than 125.
Yeah, correct.
And then moderate's probably, sorry, someone's splashing in the bath. Moderate is 125 to 1. I don't know what the normal range is. 30.
Yeah, that's right.
And then 130 to 135 would be mild.
Yeah, that's right.
I'll turn the microphone off.
Yeah, thanks. So that's one way of classifying it. So you can classify it by actually what the sodium is numerically. There's other ways as well. Does anyone know any other ways to classify hyponatremia?
Is it something to do with the regulation of the water and the sodium?
Yeah, so we can classify it by volume status. So whenever someone has hyponatremia, we always ask that they have an examination, and we want to know what their fluid status is. So whether they're hypovolemic, so dry, euvolemic, so normal, or hypervolemic, so overloaded. Now, if someone's frankly overloaded, that's really obvious, but sometimes it's quite difficult to know the difference between someone being euvolemic and hypovolemic, unless, again, it's really obvious that they're dry as a crisp. So we do have to take it with a pinch of salt, but that's another classification. So I'll move on to the next slide. So we've got 5 ways. We've got duration, acute versus chronic hyponatremia, and the cutoff that we have for that is 48 hours. So if someone has had hyponatremia for more than 48 hours, then it's classified as chronic. And that's the same if it's been drifting down over a period of more than 48 hours. Sometimes we don't have bloods, you know, if they've just come into hospital and we don't have bloods since 6 months or a year ago. And in which case, unless they've got an obvious precipitant, we would assume for safety that is a chronic hyponatremia. And the importance in that is that if it's acute and it's just suddenly dropped for whatever reason, then we would be more confident in bringing it up quite quickly. Whereas if it's chronic, then the balance of water and salt, like Nazia just mentioned, it just becomes a bit more tricky, and there's an increased risk of what everyone's worried about with hyponatremia is osmotic demyelination, or what used to be called central pontine myelinolysis. So That's what everyone's worried about with bringing it up quite quickly. So if they've had it for more than 48 hours, then we would be a bit more cautious. Next way to classify it is severity, but by symptoms, mild, moderate and severe. And I'll come on to the symptoms in the next slide. Next is the severity as per what the sodium is. So I think it was Erin said mild, moderate and severe. So mild is greater than 130, moderate 125 to 130, and severe is less than 125. We've got osmolality. So we will always ask you to check the serum osmolarity. And we want to know, we want to know if the osmolarity is low or if it's not low. So sometimes we get people that are, either fixated on the number or do serial checks of the osmolarity. If we know that it's low, that's all I need to know. So once we know it's low, we don't need to be consistently rechecking it. And if it's normal, that's unusual. And if it's high, then we would go down a completely different route, which I will come to later in the presentation. So essentially, I would say 90% of the time we'll find that it's hypoosmolar, which is just below the normal range. And I don't need to know what the exact number is. I just need to know that it's low. And then volume status, so hypovolemic, euvolemic, and hypervolemic. So that's how we can classify. And that's quite important because, as I say, with the duration, it's how quickly we can bring it back up. With severity, it's how quickly we need to treat it. And the osmolarity and the volume status help us to come to a conclusion as to the cause of the hyponatremia and therefore how we treat it. So all of those bits of information are important. So next, mild, moderate and severe. Can anyone tell me some of the symptoms of hyponatremia? And can you tell me whether they would classify as mild, moderate or severe symptoms?
Confusion.
Yep, confusion. And do you know whether that's...
That'd be severe. Severe.
Okay. Any more?
Is muscle weakness one?
I think that's probably quite a non-specific symptom. So I'll flip on to the next slide and you'll see. So essentially, even in the guidelines, we have mild. We don't really have it's just so non-specific that, people might feel a bit not right, a bit weak and fatigued, that sort of thing. And that would probably come under mild. Then we've got moderate, which would be nausea, but not vomiting, confusion, but alert, and a headache. In severe, we've got vomiting, so more than once. Obviously, it would be sort of profuse vomiting, decreased consciousness or coma, and seizures. So anyone with those severe symptoms, firstly is I would be surprised if someone had severe symptoms that were because of the low sodium, if they had a sodium that wasn't that low. So you wouldn't get someone with, a mild or moderate hyponatremia that has severe symptoms. I would be looking for another cause of those symptoms. But if someone has a really good going hyponatremia and has those symptoms, that's when we need to start thinking of hypertonic saline and escalating them up to HDU. So that's the important thing. And the confusion can be really difficult to quantify, but that's where things like your AMT come in really useful. So if they're getting worse or they're getting better, some people have fluctuating confusion with a delirium of, many causes when they're in hospital. So depending on how confused, if they start losing their conscious level or dropping the GCS, that's when we get a bit more concerned. So the causes of hyponatremia. The next slide's quite a busy slide, and we've got absolutely loads of causes of hyponatremia. So I've tried to separate them into sort of categories just to make it a bit easy to think about. But can anyone give me any causes of hyponatremia, either a category or a specific cause?
Things like burns.
Yeah. And why would the burns cause hyponatremia? By what mechanism would that be?
Because I'm sorry, I'm just driving the car, Nosheen, I apologise. Because you got that massive fluid loss with burns, so
yeah,
big fluid shift.
That is exactly right. So burns, it's not something that we see commonly, but it's something that people forget. So it's really interesting that you said that one as the first cause. I'm guessing that might be something that you've seen before.
Yeah.
So when you lose a lot of fluid. So that could be via sweating. So the other one that isn't that common, but that we think of as endocrinology is like someone that's run a marathon in the heat. You know, the London Marathon, there's always people that collapse doing that. Often they're hyponatremic. Other things are things like diarrhea, vomiting, sweating due to sepsis. So essentially losing all your salt. That can cause hyponatremia. Any other causes?
Medication.
Correct. And do you know what sort of medications commonly cause hyponatremia?
PPIs.
Yep.
SSRIs.
Yep.
Can't think of any more.
No, that's good. So PPIs, antidepressants, diuretics commonly, anti-epileptics, and there's a couple more, but they're the most common ones. Any more causes? All right.
CCF.
CCF, yeah. So do you know why that causes hyponatremia?
Shift fluids in the wrong place.
Yeah, so they're overloaded essentially. So if you've got someone that's really overloaded, it could be heart failure, but there are a couple of other causes of overload that can cause hyponatremia. Does anyone know what they are? So it could be coming from your kidneys, so they could be nephrotic, or it could be from the liver, so decompensated liver cirrhosis. So all of those will cause that massive gross fluid overload picture. Okay, so you got loads of answers there. Thank you, guys. So I've as I say, I've categorised them. So we said salt and fluid loss, dehydration. So we can get sweating due to sepsis is obviously the one that we see all the time, or exercise, burns, diarrhea, vomiting, and adrenal insufficiency. You will lose a lot of salt, and that is what will cause your hyponatremia there. Then you've got fluid overload, so heart failure, nephrotic syndrome, and decompensated liver. So everyone, if you see someone with overload, everyone automatically goes to heart failure, but just remember that there are other causes of that. Excess fluid intake. So you've got your primary polydipsia, so that's just someone that just drinks loads of water. That it may be a psychological condition, but it may be, I've had people that have just been told to drink loads of water and they think that they're doing the right thing. So I had someone that came into Barnsley who, it was something like she'd come in for an ultrasound, but she didn't need a wee and they wanted her to have a full bladder. So they told her to go off and drink loads of fluid. So she drank loads of water and then obviously like vomited loads, had a cracking headache and came in with a hyponatremia. And we did nothing, she peed it all out and she was absolutely fine, but she basically diluted down all of her salt. The other one is alcohol excess, so something called beer potomania. So we get a lot of alcoholics with hyponatremia. And then people that should be on a fluid restriction but just aren't sticking to it. That's always good to ask. Drugs, as you said, PPIs, diuretics, anti-epileptics, antidepressants. Desmopressin is something that we give for diabetes insipidus. Diabetes insipidus causes a hypernatremia, and the aim of desmopressin is to bring it back down to normal. But obviously, if they're not on the right dose or something else changes, then it'll push it further down than we mean to. And then I've put steroids and alcohol in brackets. So alcohol, I've obviously already mentioned, it is a drug. And steroids, they don't directly cause hyponatremia, but long-term steroids can cause adrenal insufficiency. So via that route can cause hyponatremia. You've got your direct endocrine causes, so your adrenal insufficiency, and then hypothyroidism, which causes a kind of, I don't really know, to tell you the truth, and it's not really that clear how it causes hyponatremia, but we treat it as SIADH, so we fluid restrict if that's the cause. SIADH itself is something that everyone always jumps to with hyponatremia, but it's, you've got a lot of other common causes as well. And with that, you'd be worried about a malignancy, especially small cell lung cancer, infection, commonly chest infection, or head injuries. And then you've got your non-hypotonic or pseudo-hyponatremias. So as I mentioned, all of those first, 6 bullet points, in all of those, you would expect the serum osmolarity to be low. If it's normal or high, it's none of these things, and it'll be something else that is interfering with the assay or causing a pseudo-hyponatremia. And that's usually hyperglycemia, so significant hyperglycemia, or it can be due to raised lipids, cholesterol, proteins, and immunoglobulins. less commonly.
Nosheen, Helen's just posted that she's looked after anorexic patients with a low sodium because of the high fluid intake.
Oh yeah, that's really interesting actually. Yeah, so sort of they're trying to keep their weight up, especially while they're an inpatient, so that we don't think they're losing weight, and they will dilute their sodium down. Yeah, thank you for that. So this is just a really quick slide about hyperosmolar hyponatremia. And there's two terms that you'll hear. Hyperosmolar hyponatremia, that occurs with hyperglycemia, so diabetes basically, and it's when it's really high. And essentially, just see the picture. It's really grainy. I couldn't find a really good picture, but this is the best one I could find. So you've got your light blue area, which is your extracellular fluid, so like your blood, and then you've got your intracellular fluid in dark blue. And between the two, you've got the same amount of sodium in both, so everything's equal. And then when you take your blood, it comes back sodium 135, whatever it is. With hyperglycemia in the blood, you've got a lot more stuff. So you've got your salts and everything else, and then you've also got a load of sugar knocking around, and that drags fluid out of your cells and into your blood. And that therefore means that you've just got more stuff in there, and it essentially, the water then dilutes down your sodium. So you've got exactly the same amount. You can see there's 5 salts there, and you've got 5 salts here. You've got the same amount of salt, but when they take the blood, it will come out as low. And there's a calculation that you can do if you go on Google and you go on, or MD Calc if you've got the app, and you can actually put in what is the sodium and what is the glucose, and it will give you a corrected glucose. So that's really useful to know. And we would like, in these people that have hyperglycemia, we would like people to do that calculation, and it just reassures people that we don't need to further investigate the low sodium, and that when we correct the high blood glucose and the sodium suddenly jumps up, we don't need to panic because it was never that low to begin with. All right, so I know that's a bit complicated. I find this really complicated, but it's just for your knowledge really. And then the pseudo hyponatremia, this is the one on the right, which is where you've got like a really lipemic blood sample. Essentially, what the lab is measuring is smaller than it thinks it is. So it that's essentially, it thinks that you've got hyponatremia, but it's actually measuring less volume of blood, because as you can see at the top on the right here, it's just full of fat essentially that's sort of stodging up the sample, and it makes it difficult. But again, it's not a true hyponatremia, so we don't need to worry about it quite so much. So that's why I kind of want to know if it's hypoosmolar or otherwise, because it just takes us down a different route and we don't need to worry about it as much.
There's a question being asked, Nosheen, by Amy. She's just asking if it was due to the drugs, example a PPI, these patients are usually on those drugs long term. Would the sodium decrease slowly?
It would be fairly slowly, but usually, yeah, you're right. So if someone's come into hospital with a hyponatremia, or they develop hyponatremia in hospital, but they've been on these medications for ages, they may be contributing, but it probably won't be the thing that's dropping it. So we probably want to look at other causes. So some people may come into hospital with a bit of a chronic hyponatremia of like 128, it's not that low, and they're on an anti-epileptic or a PPI. And in those patients, you would probably sort of say, well, what's the risk benefit? With anti-epileptics, I tend to not to mess with those at all. With a PPI, it depends why are they on it. We could change it to something like famotidine. But if it then started dropping further, despite them having been on that medication for a long time and the doses haven't changed, I would be looking for another reason. I wouldn't just put it down to the medication. If they came into hospital and we then started on those medications and then it dropped, then I would blame the medication. Is that all right?
Yeah, that's fine.
What investigations do we do for hyponatremia? So I've said a couple already. We won't start off with investigations, just the approach to the patient with hyponatremia. What do we do first?
I think so. It's just getting the basics right, Nosheen. Make sure they've had a good review, putting them on a strict fluid balance, and getting an accurate portrait of how much they're taking in and how much is going out. with some good monitoring and like a urinary catheter.
Yeah, so that's really useful. So so a proper assessment of the patient essentially. So even before we're thinking of bloods and things like that, first things first is getting the history. So quite often, you know, they always tell you like, oh, the 80% of the diagnosis is the history. I think that's especially clear with hyponatremia. So for example, if someone came in who has had burns, significant burns, and is losing loads of fluid and then becomes hyponatremic, we probably don't need to be checking their thyroid function and other things like that, because we will clearly be giving this person fluids to replace the fluids that they're losing. Or if someone comes in with like diarrhea or vomiting, we'd give them fluids. If someone came in with complaining of shortness of breath and was clearly in pulmonary edema and fluid overload, we would fluid restrict them and give them diuretics. So those sorts of things are really important. So taking the history, number one, and that does include fluid intake. So we need to know, do they drink a lot of alcohol? Do they drink a lot of water? Do they not drink any water? So some people will literally sit at home and hardly drink anything all day, and just dehydrate, you know. And then dose changes to the drugs and things like that. And then we want to examine them, so fluid status. So we all know how to do that, so I won't harp on about that. And then the next thing, we want to do investigations. So obviously we want to know what the serum sodium is, but we want to know the trend. So, you know, I had a lady recently admitted to AMU in the Northern from a GP with hyponatremia, and it was low, it was like 124 or something, but it'd been like that for years, since I think 2009 or something like that. So could have avoided an admission really, I think. So we want to know the trend. We want to know if it's always been a bit low and then has suddenly dropped down. Has it been slowly trending down? You know, you just want to know what's going on with that. And we want to know if it's like acute or chronic. Serum osmolarity, I've mentioned this a few times now. So is it low or is it not low? That's all I want to know. Urine sodium and osmolarity. So this is a bit of a pet peeve because people often just do one or the other. And it's semi-useful, essentially. So you'll hear that we want a paired sample. That doesn't mean that we want them doing at exactly the same time. What we want is for them both to have been done before we start treatment, if possible. So especially if they've got a catheter in, that should be really easy, shouldn't it? They should just be able to take a sample. So we want to know the serum sodium and then the urine sodium and osmolarity, both before we start, for example, pouring them full of fluids, diuresing in them, or whatever it is that we decide to do. And once we've got it, we don't necessarily need to repeat it if we're happy that we've got a good sample. The only issue with this is patients on diuretics will have an artificially raised urine sodium that doesn't necessarily actually fit with what the ultimate diagnosis is. It's probably raised because they're on diuretics. TSH, so as I said, sometimes people with hypothyroidism can have a hyponatremia. Cortisol, and I will come to when we do the cortisol, why and how in the adrenal insufficiency part of the talk. And then I find the UNEs, LFTs and albumin really useful. So if someone's urea is climbing, then we can probably assume that they're getting a bit dry. And as I say, you know, in general, fluid state exams can be quite tricky, especially if they're a bit borderline. So I find that urea really helpful to see if they're just getting a bit dry. LFTs and albumin. So obviously LFTs if they might be overloaded, and albumin, if the albumin's really low, then we might be thinking that they are becoming, you know, peripherally overloaded because of that. So I find those quite helpful. So this, so I don't know if you can see my arrow. So basically it comes down this side and then it jumps up here because I could only fit it on that way. And this is from the European Endocrine Society guidelines for hyponatremia. And I'm not going to go through all of it because it is quite a busy slide. But essentially what I wanted to highlight is that the first thing that we do, presuming up here at the beginning, is taking a history and examining the patient. First thing that we want to do is exclude non-hypotonic hyponatremia. So we want to confirm that it is a hypotonic hyponatremia, because if it's not, then we're less concerned about treating the hyponatremia itself. We would be treating the hypoglycemia or whatever the cause is. So it's really important. It is really important to get a serum osmolarity, and if it's anything other than low, we're going down a completely different route. We then want to know what the symptoms are. So if if it's all very acute, for example, burns or someone that's run a marathon, or the severe symptoms, so a seizure is, really obviously a severe symptom, then we go down the immediate treatment with hypertonic saline route. And that's when we're escalating to HDU, we're speaking to the endocrine consultant out of hours and all that sort of stuff. The next thing we want to know that takes us down another route is the urine osmolarity. So I don't know if I don't want to be patronising, but I used to find the whole concept of osmolarity really confusing. And the way I think about it is, especially the urine osmolarity, because it doesn't really seem to be a normal range, so to speak. It's just, what is that number? What does it mean in some context? So we look at those with a urine osmolarity of less than 100. We would say that that is very dilute urine. So if you imagine, there's only 100 osmoles in a kilogram of urine or whatever it is, that would be really like pale urine in my head. This is how I think about it. And that means that there's just not much salt and stuff going into it. And the reason for that is usually because your kidneys are just being really well flushed full of water. So in those patients, they've got such dilute urine, and the reason for that is because they're drinking loads, or they're just not taking in any salt. So it's usually primary polydipsia. So if it's less than 100, then we probably want to be really seeing what they're drinking and restricting them to back down to a normal level. And then anything over 100 is kind of more normal. And that's when you start looking at everything else. So you look at the urine sodium, but you need to look at it in the context of, is the patient dry or overloaded or normal? Are they on diuretics and other things? And then we start to come to all these other causes. So I don't know if anyone wants to take a photo of that. If I close that. It's on the European Endocrine Society guidelines, and I've got the proper title of the paper on my reference slide in a few minutes as well. So, treatment. So if we've got someone with chronic hyponatremia, it's going on a while, and they've got mild or moderate symptoms, we don't want to be bringing the sodium up too quickly. So what we can do is we can withhold any contributory medications unless there's a good reason not to. So for example, as I said, you might want to withhold an SSRI, but you probably wouldn't want to be messing with someone's antiepileptics. In patients with very dilute urine, you would, look at their fluid input and restrict them. People with hypovolemia, so they're dry, if their urine is less than 20, we just need to give them normal. So if they're dry, take away the hyponatremia altogether. If they're dry, we're going to give them normal saline, aren't we? And in those with a urine sodium of over 20, those causes may be that they're on diuretics, and that's why it's over 20, or they may have adrenal insufficiency, and that's salt. They're losing salt in their urine, and that's why that's high. But with an adrenal insufficiency, we're still going to give them fluids. So if someone's dry, essentially, we'll probably be giving them fluids. Obviously, the caveat to that is people with things like heart failure and they've been on diuretics. Maybe we've just dried them out too much. Maybe we just want to decrease the diuretics and see how they get on. But with these ones with chronic mild to moderate symptoms, we've got time. We just can do things quite gently. Next, we've got patients that are euvolemic. In those that are euvolemic and have a low urinary sodium, I'd still probably give them a bit of saline, because I'd probably say most people are a little bit dry, aren't they? Especially those that come into hospital. And if they've got low urinary sodium, giving them a little bit of saline will help. And if we want to be really cautious, sometimes what I do is I just give them like 500 mils, repeat the sodium later that day. And as long as things haven't got worse, or significantly worse, then I can try them a little bit more, but we just monitor more closely if we're not sure. And then those that are euvolemic, we're confident that they're euvolemic. There's no other cause that we can see, and the urine sodium's high, which is greater than 20, then that's when we would think SIADH, and we would go down the investigations for that. So we'd think, have they got a check? Do they need a chest X-ray? Do we need to be investigating them for some cancers? And the treatment for SIADH is a fluid restriction. But remember, in the middle of the night, well, number one, they won't be drinking anything anyway. But in someone that's got a low sodium but doesn't really have any symptoms and it's chronic, so it's been going on for at least a couple of days, we don't need to jump to make a decision. We can wait for the urine sodium to come back. We can wait for the blood tests to come back. It's rare that we need to really make a big decision. And I would say that the best thing to do, instead of jumping and either fluid restricting or giving them a load of fluids and not really being sure which way we're going, the best thing to do is nothing and do what Ed said, which is basically just monitor their fluid input and output and see which, if the patient declares that, oh, they actually don't drink anything, maybe they do need a bit of fluid. And then those that are hypervolemic, we generally fluid restrict and then give diuretics. If they're already on loads of diuretics, sometimes, it's difficult with the contributory medications. We may want to withhold them, but these aren't the sort of decisions that you just need to be making on your own. These are the sorts of things that need to be escalated and get a bit of specialty advice about, really. So those with acute severe symptoms, these are the ones that need escalating. So, the ones that are profusely vomiting, dropping the GCS, or seizing. So they need hypertonic saline. So these patients, especially if they're seizing, that 4-2's put out, and we need to be getting everyone there because we need to sort this out pretty quickly. Hypertonic saline, you can get it from A&E resource or ITU, but it should be given in resource or in level 2 or 3 care. Medical, if this is on the wards in the middle of the night, you need the med reg there, and the med reg probably should be discussing with the endocrine consultant if they're thinking of giving it. But if it's in the middle of an emergency situation like seizing, they'll probably just crack on. There's a guideline on our STH internet that's called hypertonic saline therapy in severe symptomatic hyponatremia, and that goes through everything. So it's really useful to get that up, printed out, ready. And the aim is to increase the sodium by 5 millimoles or improvement of symptoms. So if they're seizing, we want them to stop seizing, essentially. And the way that we monitor is we would do a VBG at baseline, and then we would do it after the first dose of hypertonic saline on the same machine so that we can see the trend quickly. And then we would do it, if we're giving further doses, we would do it. And we would always use the same machine, and we always need the VBG at baseline because there is always a discrepancy between the VBG and the lab UNEs. And the thing that we're worried about is osmotic demyelination syndrome, essentially. Because we're worried about bringing it up too fast, shifting the fluids around too much, and messing with the brain, basically. So other treatments, this is just to be aware of. So there's a treatment called tolvaptan, which inhibits ADH. So like causes essentially the opposite of SIADH. So it causes you to pee out water. So there's a risk of it. There's a risk of your sodium jumping up really quickly and causing osmotic demyelination. And there's a risk of volume depletion. So the patient needs to be able to drink to thirst. So we don't want, a little old lady in bed that's not going to access her own water. So we need to be choosing the patients. But it's really important that you guys, especially the ones that work out of hours and are like seeing the jobs come in and things like that, that you're aware that if someone's on tolvaptan and basically when we say that they need bloods QDS, they need bloods QDS because there is a risk that this is just going to shoot up. And once we've given them the dose, we can't undo the dose, but we can give them other treatment to try and bring the sodium back down. And then you've got demeclocycline, which is not really used as much anymore. Again, needs really close monitoring. And these patients would be fluid restricted. That slide's probably in the wrong place in all honesty, but as I mentioned earlier, with your hyperosmolar hyponatremia, with your hyperglycemias, you can calculate the corrected sodium on MD Calc, and then you would treat the cause. You don't treat the sodium. So a few pitfalls: paired osmolarities. So it doesn't have to be done at exactly the same time, but we do want it like the same day. Serial serum osmolarities are not necessary. So if you've got one and it is low, I am happy that that is low. I don't really care how low it is, in all honesty. So if you do one and it's like 260 and you do another one and it's 250, I don't really care. I just want to know that it's low. But if you did one and it was normal, I would be a bit confused, and I may ask you to repeat it in that case. Interpreting the urine sodium on diuretics. So if you're making like a referral to endocrine and you've done all these tests, which is really great, but then if someone's been on diuretics, just mention that because it's really important for us interpreting the results. Monitoring fluid intake is just hard in hospital, isn't it? But it is really important. SIADH is a diagnosis of exclusion. So don't just assume people have SIADH unless we've gone through everything else in a sort of methodical way, and that's what we think it is. Alcoholics, so people drink a surprising amount, and especially beer drinkers, the volume can be huge, can't it, with beer? So if you're drinking 10 pints a day, that's like 5 extra litres on top of what you're drinking, water, tea and everything else. And the other thing with alcoholics is that, in my experience, the people that are alcoholics, they have really, really low sodiums but they're also malnourished. They're also at increased risk of seizures anyway from the alcohol and then from withdrawals. So those patients are really high risk, and you just need to be aware that have a very, very low threshold for escalating them. And then we aim for an increase in the serum sodium of not more than 10 in the first 24 hours and 8 in each subsequent 24 hours. We are not concerned about it jumping up in hyperosmolar hyponatremia, so the ones with the diabetes, because it's not a true hyponatremia. And if the sodium isn't that low, we're not going to cause them damage, and it's not going to jump up that quickly anyway. But we don't need, if it's not that low in the first place, we don't need to be monitoring like 4 times a day or twice a day or anything like that. And treatments with withholding medications or giving a bit of fluid or fluid restricting don't work straight away. The ones that we need to be doing sodiums on, twice a day, they're the ones that have got really low sodiums, like less than 115, 110 especially. So who should be escalated? So acute or severe symptoms for hypertonic saline, severe hyponatremia, the lower the sodium, the higher the risk. I start as an endocrinologist. I know that the severe hyponatremia is technically less than 125, but from an endocrine point of view, we start to get concerned really if it's less than 115, and if it's less than 110, then we're really concerned, and we would rather they were on HDU. If we don't know the cause of the hyponatremia, we need to escalate it because we don't know what treatment to give them until we know the cause. And those with rapid rises in sodium really quick, then we start to get a bit twitched, and they need discussing with the endocrine, consultant out of hours or reg during the day. So this is where I got that flow chart from. So if anyone wants to take a picture, then I'll give you a second. So that's the end of the hyponatremia part, and then I've got the adrenal insufficiency part next. So does anyone want to ask me any specific questions on hyponatremia before I move on?
I've got a question. If someone's got a long-term conditions such as lung cancer, normally they have a low sodium. So would we still investigate them, do the serum osmolarities if they're being acutely unwell?
Yeah, so if they've got a long-term condition like lung cancer, but have they got a new hyponatremia?
Say it was like 125 chronically for the last, according to the ICE, last 3 months.
So if it hasn't been investigated before, we would probably still do all the same things. So we would look at their medication, we would look at their fluid status, we would look at their osmolarity. Yeah, so I would do all that, but unless there's something else going on, small cell lung cancers, and it's a chronic mild hyponatremia, it almost certainly is SIADH. But before I start, committing that patient to a fluid restriction, I would like to rule out that it's not something else.
Okay, cool. Helen's just asked a question. Do alcoholic patients or patients with chronically low sodium tend to have fewer or less signs of symptoms of hyponatremia?
Yeah, so those that have had a very slowly dropping sodium, you would expect that they can tolerate it surprisingly well. So I think there was a patient once when I was on Hadfield, so at least a few years ago, who he did seize eventually, but I think he came in with a sodium of like 96, and he was a drinker and he had some other things going on as well. So those ones with really low sodium, they usually have more than one reason for it. But if it's dropped slowly over a period of time, your brain does sort of compensate and you may have less symptoms. But that compensation from your brain is the real reason that we need to be really cautious bringing it back up. As opposed to, for example, your London Marathon runners who've collapsed with hyponatremia, who you can be pretty sure that it's because they've just sweated out all their salt. Their brain hasn't had a chance to compensate, and that's why we need to bring it up really quickly. And they're acute, so we're less worried about bringing it up quickly.
Okay.
Any more questions? Okay, so next, an adrenal crisis. So not that commonly seen, but it is something that I think worries a lot of people. So we'll go through what it is, who is at risk of developing an adrenal crisis, when should we be checking cortisols, and how do we manage it? So does anyone know some of the symptoms of an acute adrenal crisis? Or does anyone know what it is?
No, I don't.
No, that's absolutely fine. So it is a life-threatening emergency, and it's caused by a relative or absolute cortisol deficiency. So cortisol is your stress hormone that is released by your adrenal glands that sit on top of your kidneys in both flanks. And your adrenal glands are essentially like switched on and off by your pituitary, which is in your brain. And if for whatever reason your adrenal glands aren't working or aren't working enough, then that, if you've not got cortisol, then when your body's stressed, what should be happening is it should be, you know, squeezing everything and pushing up your blood pressure to keep you alive. So, you know, keep you standing upright and keep you off the floor, basically. And if you've not got your cortisol, well, in a chronic scenario, you won't feel very well. I'll come to that in the next page. But in an acute scenario, so for example, it might be something like an operation or sepsis or a car accident, or even like emotional stress, like your spouse dies or something awful like that. And when normally your body gets that, you know, that stress feeling, it keeps you upright and keeps you alive. If your body doesn't get that, then essentially everything just goes to pot and your blood pressure drops and, you know, you are shocked. You are properly shocked. So these symptoms are hypotension and shock, not responding to fluids, vomiting, abdominal pain, collapse, and also hypoglycemia. So essentially, if someone is shocked and they're just not responding to treatment, if you don't know what's wrong with them, an adrenal crisis can be in the back of your mind. Conversely to that, adrenal insufficiency, like the chronic sort of thing before they have developed a crisis, it's a bit less specific. And you've got your fatigue and weight loss. You may have low blood pressure, but it might be postural, and you may have symptoms of that, as opposed to frankly being shocked, hypovolemic shock. Nausea, salt craving. So you may, you know, get these patients that have Addison's that are peeing out loads of salt, and they just want to eat loads of crisps. Hyponatremia, hypoglycemia, and the pigmentation that sometimes people talk about with this is specifically for Addison's, but there are loads of other causes, either affecting your adrenal glands or affecting your pituitary, which then has a knock-on effect of your adrenal glands. So does anyone know who may develop an adrenal crisis? So who do we need to be having this, you know, high up in our differentials?
Yeah. Patients on long-term steroids?
Exactly correct. Anyone else? That is the main one, and that is one that we see in hospital all the time. So again, I've done it like I did with the hyponatremia, and I've sort of separated them into things that just help me think about it. So we've got the patients that we know have hypoadrenalism, and that might be because of Addison's disease, which is the autoimmune cause. It might be because of an adrenalectomy. So we do get these ones in Sheffield because we have the endocrine surgeons. So we actually get those people having adrenalectomies in our hospital, and then patients on long-term steroids who may be then known to have hypoadrenalism. So they should be, you know, counselled on it and have steroid safety advice. But often when you come into hospital, these things may not be addressed.
Sorry again. Helen's asking, what about patients presenting with palpitations or thyroid patients?
As a cause, what are they at risk of adrenal crisis?
Adrenal crisis.
So let me think. So patients presenting with palpitations, and they are then subsequently maybe found to have hyperthyroidism. So sometimes you can get the two associated because they are Addison's disease specifically is autoimmune, and Graves' disease, which is a cause of an overactive thyroid, is also autoimmune. But you wouldn't assume that that person with palpitations was having an adrenal crisis unless they were having specific symptoms of an adrenal crisis. You would treat the overactive thyroid. You may have heard, the reason that you may be thinking this way is you may have heard that sometimes patients with hypothyroidism, we want to check a cortisol before we start them on treatment. Is that something you've heard?
Yeah.
Yeah. So essentially, the reason for that is, so patients with hypothyroidism, unless they've had something like an operation to remove their thyroid or something like that, it's often, again, an autoimmune cause. And the theory is that if they've got one autoimmune condition, they may have another autoimmune condition, for example, Addison's disease. And the symptoms of hypothyroidism in Addison's can overlap, you know, the tiredness, the fatigue, generally feeling unwell. And they say that before you start the treatment for hypothyroidism, you may therefore want to check a cortisol to check that they don't also have hypoadrenalism. We don't always do that because so many patients have hypothyroidism. GPs, I don't think they would ever really, unless there was another reason to go down that route, wouldn't be checking a cortisol in all of those patients.
Okay, right.
All right. So patients with known hypopituitarism, so surgery to the pituitary or like cranial radiotherapy, things like that, head injuries. So long-term or recurrent steroid courses. And remember that it's not just like your PREDs with your COPDs, it's your people that have like joint injections every 3 months, or they're on topical steroids for whatever reason. So it is important. If you look on the summary care record, don't just look on their regular medications, look on their acute and their discontinued, because they may have had more steroids than they will admit to. And it might be that they're on long-term steroids for their hypoadrenalism, for their adrenal insufficiency, but they may be on steroids for something else. And it might be that they've just finished a course and it's not been weaned down because they've only had 5 days, but when the GP looks back, actually you find out that they've had 5 days every couple of weeks for the last 2 months. And so it might be that they've missed a dose, they haven't weaned, or they've weaned very quickly, or that they're on steroids and then they didn't know that they should be doubling their dose during time of illness. Less commonly, someone that's got a severe acute illness, they can have an adrenal hemorrhage or infarction, or they can have a head injury that takes out their pituitary. So less common, but basically people that are really unwell can take out their adrenal at the same time. And then it may be that they have a first presentation of Addison's that just happens to coincide with something else that's going on, like infection, sepsis, childbirth, surgery, an accident, or emotional stress. So all of those things can bring on an adrenal crisis. The more common ones are the ones with steroids and the known hypoadrenal or hypopituitarism that was mentioned. So the management, number 1, is be aware that this is a thing, because you will never treat it if you don't think about it. I've put them in this order, but the most important thing for the treatment of this is to give them steroids. And you can give IM hydrocortisone 100 milligrams or 200 milligrams. I have absolutely no preference. If they're really sick, just give them 200, the more the better. As a stat dose, IM, you're not delaying the dose to put a cannula in. If they're really sick, they're then going to go to HDU and have a continuous infusion. But if they improve and for whatever reason they stay on the ward, we would give them 100 milligrams 4 times a day, so every 6 hours. And we can prescribe it IV or IM. IM has a better release of the medication. Obviously, I guess the patients would prefer IV, but what we don't want is them to then miss a dose because the cannula falls out. That would be absolute worst case scenario. If we're able to take bloods before we give the steroids, we want a cortisol and ACTH. Cortisol comes from the adrenal, ACTH comes from the pituitary, and it helps us figure out where the problem is, if it's the brain or the adrenals. If it's too difficult to do that, they're hard to bleed, do not delay giving the steroids. We'll sort out the blood test later. And we resuscitate the patient because they're shocked and treat whatever we think is going on. So if they've got an infection, we'll give antibiotics. And they need loads of fluid and they need escalation to HDU at least. Refer to us. So when do we check a cortisol? So this comes up all the time, doesn't it? So if we think a patient has adrenal insufficiency, then we want to check a cortisol. If they have specific symptoms of adrenal insufficiency or crisis, then we want to check a cortisol. And then there's some patients that are having their steroids weaned, which is more of an outpatient thing, so probably not something that you'll see too often. But we don't just check cortisols randomly. We only do it if we think they have adrenal insufficiency. And when do we do it? So if they are acutely unwell, as per the last slide, we do it straight away before giving steroids. If we can't do it straight away, we give the steroids, we treat them, refer to us, and we'll sort out the bloods later. In everyone else, if they're well, we can wait until 8:30 the next day. And the reason for that is, I should have put a slide in here with a picture really, but essentially the cortisol, it's your stress hormone, it gets you out of bed in the morning. Obviously it's all messed up with us like doing all these shifts, but for normal people that don't do shifts like us, you get a peak at around 8:30, 9 o'clock in the morning, and that's when it's at its highest. And then theoretically it should, go down during the day and be really low at night while you're asleep. So what we want its peak, and we want to know what that level is. So if someone's really well and has really non-specific symptoms, or for example hyponatremia, and it's like 4 o'clock in the afternoon, or 2 o'clock in the morning, doing a cortisol, it's not overly helpful, because if it's not above 350, I'm just going to say repeat it at 8:30 anyway. If someone's been on steroids recently, it will 100% be low, and checking it isn't helpful, because all I'm going to say is needs checking again later. So if you can see from, that someone's been given pred recently for a COPD exacerbation or something, you can just make a note of that in the notes. I have not checked the cortisol for this patient with hyponatremia because they're on steroids. It will be low. Okay, cases. So let's bash through a few. So this is where a pen might be useful. So 91-year-old lady who was admitted from a nursing home, and she's acutely confused with GCS of 14 out of 15. There's been a noro outbreak at the nursing home, and she's had diarrhea and vomiting for the last 2 days with hardly any oral intake. Her background is Alzheimer's and hypothyroidism, and she takes donepezil, which I'll just tell you isn't a causative medication, and levothyroxine and PRN paracetamol. So observations, she's a bit tachycardic, borderline hypotensive, respirates 21, sats are fine, temperature's a little bit on the low side, and she's got hyponatremia, hypokalemia, and probably, I don't know what her old unis were, but probably a bit of an AKI. So my first question is, can anyone describe this hyponatremia for me? So based on what we discussed right at the beginning, what information can we get just from this history that tells us anything about this hyponatremia?
It's acute, isn't it? Because she's had DMV for 2 days.
So it possibly or probably is acute, yep.
And it's severe. Helen just put her finger up. It's severe hyponatremia.
Yep, so it's severe as per the number. So it's less than 125, so it's severe. What about the symptoms?
And the symptoms are secondary to diarrhea and vomiting. No.
So the symptoms of the hyponatremia, is that mild, moderate, or severe?
Mild.
Moderate.
Moderate, sorry.
Yeah, moderate, because she's acutely confused. And then we've not got the osmolarity, but based on her fluid assessment, we've not done a formal examination, but based on her history and her obs, where do we think she goes in her fluid status?
Dehydrated, so
Hypovolemic. Yep, correct. So based on that, before we've even done any specific investigations into this, what do we think the cause of her hyponatremia is?
Dehydration.
DMV.
Yep, DMV, so she's dehydrated, and therefore the treatment is?
IV fluids.
Correct. Is there anything else we need to do? So do we need to wait for any other investigations to come back before we start treating this woman?
No.
No, but you could take the osmolarity before you start the fluid.
Yeah, that would be great. Yeah, so before you start the fluid, you can add on a serum osmolarity to the bloods. And if we're sticking a catheter in for this acutely unwell lady, we can send off a urine sodium and osmolarity. That would be perfect. And how would we monitor this lady? And is there anything specific that we want to monitor?
Her fluid balance and remain on the ward care level.
Yeah, so she'll probably be for ward level care. We want to be doing daily U&Es. We want to be doing a fluid status. And is there any other investigations that we want to do in this lady?
An ECG and check her magnesium as well.
Yeah,
because her potassium's low.
Yeah.
And to rule out infection.
What was that last one?
Sorry, stool sample, thinking infection. No.
Yeah, but from a sodium point of view, any more specific investigations? So we'd want to do a TSH because hypothyroidism is also a cause of hyponatremia. Yeah. But we would be able to treat that whenever. We can do that whenever. We want to give her fluids regardless, don't we? So I've said likely and acute severe hyponatremia with moderately severe symptoms and hypovolemia. She's due to salt and fluid losses secondary to DMV. The treatment is fluids. We need to examine the patient as well. She seems dry, but obviously with regards to the rate of fluids and things like that, we would do an exam. We'd monitor her with repeat UNEs, and after we've given her fluids, repeat the examination. We'll add on a serum osmolarity and TSH. We will not be postponing the treatment in order to do any other investigations because this patient clearly needs fluids, and we would never fluid restrict a dehydrated borderline hypotensive patient. I know that's really obvious, but you would be surprised how often patients get just randomly fluid restricted because of hyponatremia. Okay, next. So this is a 75-year-old male who was admitted under trauma and orthopedics with a NOF a week ago. Post-op, he developed a HAP and was treated with TAS. He feels generally unwell, but no specific symptoms of hyponatremia. His background is a stroke and hypertension, and his drugs are aspirin, candistatin, cholecalciferol, simvastatin, omeprazole, moxonidine. I think it's just the omeprazole in there that's a causative medication, really. He looks fairly euvolemic. There's definitely no signs of overload, and he's not got any specific losses that we can see. So sodium has slowly been dropping since admission, so it's dropped from 134 to 123. They've done all the investigations for us, so his serum osmo is low. Urine sodium is quite high at 66. Urine osmolarity is 534, so it's not less than 100, so that's what we're interested in. The urea and creatinine, he's not dry. TSH is normal, and a 9 AM cortisol is also normal. So everything on there is normal, but of note, he's got hyponatremia, hypoosmolar, and a raised urinary sodium with that background. So my questions this time are, so we can describe the hyponatremia, but I've pretty much done that for you, sorry. So what potential causes are there for this patient's hyponatremia?
Could be as omeprazole.
Mm-hmm.
It looks more chronic, because it says it's slowly dropping.
Is there anything else in here that could cause a hyponatremia?
Sepsis from his HAP.
So yeah, that's a good point. So if he was septic, then we might be thinking that he was febrile, sweating out his salt, which could cause it. But he's on examination. I've not mentioned his OBS actually, but let's say he's sort of recovering from his HAP, but he has still got, he's got that HAP on the chest X-ray, and he's euvolemic with a raised urine sodium. So this is one of those patients that you might actually be thinking of SIADH. So in this case, with the raised urinary sodium, so if he was sweating out all his salt, his urinary sodium would be low. So if it was secondary to sepsis, we would want to be treating him with fluid, but his urinary sodium would be low, and he would be more on the dry side. He might have a raised urea. In this case, he's got the HAP, but he's sort of well with it, but that can cause an SIADH, and that causes the urine sodium to be higher. Does that make sense? So this is one of those patients. But again, this patient, we've investigated this over a period of days. This all doesn't need to be sorted in the middle of the night. And the treatment for this chap, well, what would be the treatment if we think he's SIADH? I can't remember if I've already said it. So treatment for SIADH would be, in this case, a fluid restriction. Okay. So he's also on a PPI, which someone mentioned. Oh, and candistatin, I missed that one. So important to know, are those medications new? Have we increased the doses? Could that be the cause? We also want to know what his fluid intake's like, and we would potentially omit those causative medications and fluid restrict, and we'd do daily UNEs just to check it was on its way up before we send him home. Case 3 is quite wordy, so I'll just summarise it for you. So 78-year-old woman admitted with an NSTEMI 10 days ago, and is now becoming overloaded, so leg swelling, increase in oxygen requirement, has all the usual comorbidities, stroke, hypertension, type 2 and CKD, all of the usual suspects. So aspirin and ticagrelor, which was started for the NSTEMI, atorvastatin, bisoprolol, ramipril, amlodipine, metformin, empagliflozin, which has been withheld because you do that in when they come into hospital, folic acid, dalteparin, and omeprazole. So causative medications there really are just the omeprazole and possibly the ramipril. So on examination, heart rate is a little bit fast and irregular, blood pressure's fine, tachypneic, hypoxic, and they look short of breath, they have crackles, raised JVP and pitting edema. And the sodium has dropped from 131 2 days ago to 121, and the urea and creatinine are rising, but the albumin is fine. So can anyone describe the hyponatremia for this patient?
Hypervolemic is possibly in failure.
Correct. So he seems overloaded, so this is probably a hypervolemic hyponatremia. Anything else that's important to know about this?
She's in heart failure. Amy Moody's just put on one of the comments.
Yep, correct. So we think that the cause of the hypervolemia is probably heart failure based on the history.
Her renal function's worsening, so she might actually be dry as well.
Yeah, so it's tricky, isn't it? But sometimes we get an AKI just because the heart's not pumping very efficiently and it doesn't perfuse the kidneys very well. So it's a bit difficult to know that one. But yeah, that is correct. So we think that the cause of the hyponatremia is fluid overload secondary to heart failure, and they've also got an AKI. So what treatment would we want to? How would we treat this patient?
Diuretics.
Yeah, and anything else?
Would we get a chest X-ray? Are we talking about basics like assessment?
Well, with regards to the hyponatremia.
Oh right.
But yeah, definitely do all those bits as well.
Definitely a fluid restriction.
A fluid, yeah. And a fluid balance as well.
So we would fluid restrict and we would give diuretics. And my next question was going to be, what are we concerned about? And it's been mentioned already, the AKI. So we might be concerned that they're a bit dry but peripherally overloaded. But what I would say is that ABC comes before kidneys, which are way down the list, aren't they? And this patient is hypoxic, the respirate's going up and they're starting to struggle a bit. And they are frankly overloaded. The JVP is up to the earlobe as well, which might make you think, they're properly intravascularly overloaded. And that congestion of fluid can cause an AKI. So actually, fluid restricting and diuretics in this case, as well as helping the fluid overload, the pulmonary edema and the hyponatremia, probably will also help the AKI. So from a hyponatremia point of view, is there any other specific investigations that we've not done here?
Would you do the serum paired osmolalities?
Yeah, so we would definitely need a serum osmolarity, because we always do, just to make sure that we're not missing something else. A urine osmolarity and sodium would be helpful, but we may consider that there'll be it'll all be messed with because we'll have started giving this patient frusemide now, won't we? So it'll be difficult to interpret. But yes, the answer is serum osmolarity. But we don't think anything else is going on. It looks, from the history and examination, it seems quite clear what's happening, and we are quite committed to a course of treatment at the moment. So case 5 is a little bit different. So it's a 55-year-old man who came in with an acute ischemic limb and underwent endovascular intervention overnight. He has no past medical history, but he's a smoker. He never attends a GP and is not on any medications. So he may well be a well person, but considering he's just had an acute ischemic limb, he's probably not as well as he thinks he is. So he has no previous bloods to see. So his sodium has come back 126, potassium's fine, urea is 10.9, creatinine 98, and his serum osmolarity is 301 with a normal range of 275 to 295. So does anyone want to describe this one? This is a little bit different.
So is it mild hyponatremia?
So mild from a symptomatic point of view. I don't think I've actually said his symptoms, but yes, he has no specific symptoms, so it is mild. From a numerical point of view, is it mild, moderate, or severe?
Moderate.
Correct. And then acute or chronic?
It says nothing to compare to, so I think would get further investigations or do a random BM to see if the BM is raised.
So that's exactly right. So why are we thinking that we want to do a BM?
Because it's got an ischemic limb and is presented with a new hyponatremia and a raised hyperosmolality, which could be hyperosmolar.
That's exactly right. So he's got a hyperosmolar hyponatremia. This is the first one of the cases so far. Everything else has been low, and this one is high. So yes, that is exactly right. So we would assume that this is a sort of a chronic hyponatremia because we have nothing to compare it to and he has no specific symptoms. But then when we look at the serum osmolarity, you think, oh, actually, it's probably not a true hyponatremia. It's hyperosmolar. So that's what's different about this case. And the main investigation that we want to do is a BM, but we've done a lab blood glucose and it's 40. It's probably high. And he's diagnosed with type 2 and is referred to the diabetes team. So we've done a calculated serum osmolarity, which I've done an MD calc. And if someone, this is actually correct. So if someone came in with, what did I say? Sodium of 126 and a lab glucose of 40, it works out that the actual serum sodium is 136. So we can write that in the notes. And does the hyponatremia, not the diabetes, that will be looked into, but does the low sodium need any other specific investigation or treatment at this point?
I would say no.
And that is exactly correct. So we can be very reassured that the sodium isn't actually low. It's just because of the way that the high glucose messes with the results. And once we've calculated it, we can be very reassured he's actually got a normal sodium. And what needs treating is actually the glucose. So we refer him to the diabetes team as a new, probably type 2.
True.
And I think this might be the last one. Yes. So this is a 28-year-old lady who came in last night with a perforated appendix and went straight for surgery. She has type 1 diabetes and celiac disease and is on Levemir Humalog and a gluten-free diet and is now on a variable rate post-op because obviously type 1 and she's had an operation. During the operation and since, she's been persistently hypotensive, tachycardic, vomiting, and she looks awful. She's so far been fluid resuscitated with IV antibiotics and a litre and a half of normal saline. We know that she's got a perforated appendix, so she's probably got a bit of sepsis going on as well, but she's mildly febrile. She's properly tachycardic and hypotensive. She's peripherally cool and shut down. She looks awful. She's got a bit of a lactic acidosis. She's actually hypoglycemic, and she is also hyponatremic. So, what are people's thoughts on this case, considering what we've been discussing today?
Is it an adrenal crisis?
It is an adrenal crisis. So that is, yeah. So my first question was, what are the potential causes of hyponatremia? So in this case, I would say
she's dry secondary to theatre.
No, she's having an adrenal crisis. So yeah, it's difficult when people have gone for theatre and then you say, oh well, obviously she's had a perforated appendix. How much has she had to drink at home? Probably not much. And then she's gone to theatre. Did we give her enough perioperative fluids? And she's probably a bit septic. But let's say this lady, let's say we just keep giving her fluids. We keep giving her fluids. She's now up to 5 litres of fluid and things are just not getting better. Obviously, we don't want to let it get to that stage. So I probably should have, for the history, just for the sake of this, said that she'd had 5 litres of fluid. But yes, she's having an adrenal crisis. But yeah, you're absolutely right. She might just be dry because she's not been eating because she's had tummy ache for 2 days, and she may be hypoglycemic because she's on a variable rate. So it's very, very tricky. But essentially, this lady is having an adrenal crisis. So what do we want to do?
Give her steroids.
Correct. How much?
IM hydrocortisone.
Exactly. Yep, correct. And as well as giving her the hydrocortisone, what else do we want to do?
Treat the hypo.
Oh yeah, definitely. Yeah, absolutely.
Would we treat the hypo first and then give her the steroids, or just give her the steroids as well as?
Just give her the steroids.
Yeah,
just give her the steroids. Yeah, just give her the steroids, and then, you know, at the same time we can give her some whatever we want to give her for the hypo. Probably IV Dex, isn't it, for this lady? But give her the steroids, number one. Is there anything, if we get a chance to do, that it might be quite nice for, you know, for your endocrine reg? Yeah. So if we get a chance from her other arm that doesn't have a load of fluids going into it, if we get a chance before, you know, while they're running to get the hydrocortisone, if we can get some blood, we can send a cortisol and ACTH. It's very useful for us. And in the meantime, we're just going to keep fluid resuscitating her. And ultimately, what do we need to do with this lady? We need to send her to
HDU.
Yeah, exactly. So this lady is sick, like really sick. I mean, everything that you guys just said is right. That actually, so in my head, I've made up this case, so this isn't real. I was thinking adrenal crisis, but absolutely right. She may well just be dry, and we just need to give her more fluids. But if someone isn't improving, and this lady is young, and she has type 1 diabetes and celiac disease, so we're thinking autoimmunity, and then she's had this trigger. Oh, yeah. So this may be a first presentation of Addison's disease. I could have easily written this as someone that's, you know, had a heart attack and then has had loads of steroids recently for their COPD or something like that, and that would be a completely different reason, but it would all come to the same thing. You just need to give them steroids. If you're ever in doubt, no one is ever going to be mad that you've given someone an extra dose of steroids. Sometimes, if I don't know what's going on with the patient and they're hypotensive or they're really, really sick, just give them some steroids. It not to make anything worse. So, adrenal crisis, bloods, hydrocortisone, fluids, antibiotics, escalate, and refer to us for the next day. So that's the end of the talk. Has anyone got any more questions?
Not at the moment, but that was really good. Thank you.
Yeah, that was brilliant today. Thank you very much. So yeah, as usual, if anyone thinks of anything later, I'll turn off my screen sharing now, then absolutely feel free to send me an email or anything like that.
Can I just ask? Hi, I'm Lauren. I work in active recovery in the community. This is very, very basic. So a lady went in last night because her bloods the sodium was 129. Mm-hmm. They checked him in A&E, it was 130. They turned her straight around and she come home. Mm-hmm. Is there anything that we should be worrying about with regards to that? Probably not. Seems really mild compared to all these numbers that you've thrown at us today. Well, it's hard, isn't it? With the numbers don't really mean anything unless you've got the context, doesn't it? Yeah. Someone with 129, it's just in the moderate range. I would want to know if she was having any symptoms, but I would be surprised if she was having no symptoms. Yeah. So essentially, what I would be thinking with this lady is I want to know her fluid status. So if she was, for example, if she was seen by a doctor and then you said, oh, I better see her because she's got a new just about moderate hyponatremia, and she was frankly overloaded, she may need to come into hospital to have that investigated and treated. But for the sodium itself, I probably would have kept her at home, and I would have probably looked at her medications, done a medications review, and considered looking to see if she's got hypothyroidism or anything else like that. But to be honest, I wouldn't have admitted her. I mean, probably the omeprazole. She's on about 3 tablets. There was no fluid overload, no dehydration. I mean, when you look back on ice, there's been odd occasions of it dropping, so it could be the omeprazole. So that might be something. Yeah. So it could well be the omeprazole. It might be something to do with she may be drinking loads of water or not drinking any water. She may drink more alcohol than she admits to, which most people do. We could check TSH and see if she's a bit hypothyroid. But regardless, I think when you've done all those bits, you can still do a serum osmolarity as an outpatient, and you could still do a urine sodium and urine osmolarity as an outpatient as well.
And I guess the thing that people really worry about missing is an SADH and some sort of underlying cancer.
Yeah.
But cancer is usually diagnosed as an outpatient, isn't it? Not an inpatient.
Yeah.
So that is one of those things that you can say, if that's the way that you were thinking, you would ask about the red flag symptoms, and you would choose you'd probably want to do a chest x-ray at least, consider doing a CT chest abdo pelvis if indicated. But if it's something that's been on and off for like years, yeah. But these things can be investigated as an outpatient.
Yeah. Thank you.
Oh, you're welcome. Anything else? Or any specific cases that you want to discuss? Good.